Right. Okay. So hi everyone. Thank you so much for joining us for this tutorial. So today's tutorial is a cardiology tutorial on atrial fibrillation, and it's given by Catrin. Just a few rules. If you're watching via Zoom, any questions or comments that are in the moment that are covered in the moment, if you just want to pop it into the chat, and any questions that can wait to the end, if you just want to pop it into the Q&A. If you're watching on the Facebook Live, just comment your questions in your comments, and I'll pass them on to Catrin. And that's all from me now. I'll just pass it over to Catrin. Thank you.
Cool. So good evening, everyone. So as mentioned, I'm Catrin. I'm currently a fourth year medical student at Bartram, London. And today I'll be giving a tutorial on atrial fibrillation or AF. So here's just a bit of a disclaimer at the very start. So our learning objectives for this tutorial today are going to be: what is atrial fibrillation to start with? What causes it? How does it typically present in the clinical setting? We also are going to be looking at how to investigate a patient with AF. How do you then proceed to manage these patients? And then we're going to have a look at some of the complications that may arise, as well as the prognosis to think about. So, what is atrial fibrillation? So atrial fibrillation, or AF, is typically described as a supraventricular tachyarrhythmia, which is characterized by an uncoordinated atrial activity on the surface of an ECG that is typically associated with an irregular ventricular response when atrioventricular conduction is intact. Now, because AF leads to impaired filling of the ventricles, as a direct consequence, less blood is going to be pumped out with each ventricular contraction. Therefore, AF as a whole leads to the stagnation of blood in the atria, leading to thrombus formation and a risk of PE, increasing the risk of stroke, and leading to a reduction in your cardiac output, especially during periods of exercise, for example, which can lead to consequences like heart failure. Now, there are a number of ways in which AF can be classified, and so these include, for example, acute AF. So that's where the onset of AF is typically within the previous 24 hours. You can have paroxysmal, which is where the AF spontaneously terminates within about 7 days. More often or not, it will terminate within about 48 hours. Importantly to note, paroxysmal AF has the potential to degenerate into a sustained form of AF. There's also persistent AF, so that's not self-terminating, and that's typically going to last a bit longer than 7 days. Again, persistent AF has the potential to degenerate into permanent AF. And then the last form is permanent atrial fibrillation. And so that's where there is AF that persists for over a year in duration, and it's not successfully treated by, for example, cardioversion. And cardioversion is a procedure by which you have an abnormally fast heart rate or a cardiac arrhythmia like AF that is converted to a normal rhythm using a therapeutic dose of, for example, an electrical current. So it's always important to note the epidemiology with any sort of pathology that we're looking into. So for AF, this is the most common sustained cardiac tachyarrhythmia, and there are estimates do suggest that its prevalence and incidence is increasing worldwide. These estimates also do indicate a prevalence of approximately 3% in adults aged 20 years or older, with a greater prevalence occurring in the elderly population, as well as in patients that have other comorbid conditions like hypertension, heart failure, coronary artery disease, as well as diabetes. And also important to note is that it's recognized that AF is more common in males than it is in females. Cool, so moving on to our first MCQ question. So what form of AF spontaneously terminates within about 7 days and most often within 48 hours? So I'm just going to put up a poll. And if you can all vote on what you think is the correct answer. So almost there, just a couple more people we're waiting for. Cool, so we'll end the poll and we'll share the results. So, yep, about 67% of you actually got that correct. So it is paroxysmal AF. Perfect. So now we're going to move on to the etiology of AF. So what causes it and how does it normally present? So most people with AF have some kind of identifiable underlying cause. So for example, coronary heart disease, hypertension, or valvular heart disease. There is also importantly such a thing as lone AF. And so that's where there is no obvious cause and all of your investigations are normal. And this will typically occur in about 11% of patients with AF. Other factors that are thought to cause or to be associated with AF include less common cardiac causes like cardiomyopathy, pericarditis, myocarditis, an atrial septal defect, or a congenital heart disease. You can have non-cardiac causes. Those include things like drugs like thyroxine. You can have an acute infection, electrolyte depletion, or thyrotoxicosis and diabetes. And you can also have things such as dietary and lifestyle factors. For example, excessive caffeine intake, excessive alcohol intake, as well as obesity. In terms of presentation, if you were to feel the pulse of a patient with AF, you would expect to notice that they have an irregular pulse, first of all. If you were then to perform an ECG of this patient, you would see some diagnostic features, namely a variable RR interval and the absence of a P wave on your ECG trace. Other signs and symptoms that can also present in a patient with AF include, for example, breathlessness, palpitations, syncope, chest discomfort, as well as the potential for stroke. Cool, so moving on to our next MCQ. So this is, what is the distinguishing feature of AF on an ECG trace? Okay, so if you vote on what you think is the correct answer. We'll wait for a couple more votes. We've got 7 out of 11 people so far. Cool. So we will share the results. And yep, 75% of you guys got that correct. So absolutely, it's the RR interval. So this is the time elapsed between two successive R waves of your QRS signal. And that's going to be telling us about the heart rate variability. And a variable RR interval is one of the distinguishing features of AF on an ECG trace. Cool, so moving on to investigations. Right, so when investigating for potential AF in a patient, we need to firstly identify the underlying cause which has led to this, and that will ultimately influence how we then go about treating this patient. And two, we want to assess cardiac function. So an ECG should be performed in all patients, whether symptomatic or not, in whom AF is suspected because an irregular pulse has been detected. In patients with suspected paroxysmal AF that has gone undetected by standard ECG, then you can perform a 24-hour ambulatory ECG monitor. And that's for if you suspect asymptomatic episodes or symptomatic episodes that have occurred less than 24 hours apart. In terms of your blood tests, you want to be looking at your FBC, your renal function electrolytes, for example, for any abnormal serum potassium levels, which can potentiate an arrhythmia. Your LFTs, your thyroid function, because thyrotoxicosis can sometimes present with AF, and a coagulation screen if you're going to be giving the patient warfarin. An echo is typically indicated in patients in order to exclude any abnormal cardiac pathologies, like a cardiomyopathy, for example, or if the patient is scheduled for cardioversion in order to help exclude the presence of a left atrial thrombus. And that would normally be contraindicated in both cardioversion as well as catheter ablation in those sorts of patients. Cool. So now moving on to management of a patient with atrial fibrillation. So in terms of patient management, this is normally going to be aimed at controlling the arrhythmia and then giving thromboprophylaxis in order to prevent the onset of a stroke. Now, depending on the type of AF that a patient has, this will determine how we treat them. So, for example, in a hemodynamically unstable patient with paroxysmal or persistent AF, your first line form of treatment is going to be direct current cardioversion. And so DC cardioversion is performed under adequate short-acting general anesthesia, and that normally involves the delivery of an electrical shock that has been synchronized with the intrinsic activity of the heart by sensing the R wave of the ECG. And timing the shock to the R wave prevents the delivery of electrical activity or electricity during the vulnerable period or your relative refractory period of the cardiac cycle, which could inadvertently induce ventricular fibrillation. In a hemodynamically stable patient with paroxysmal or persistent AF, your first line treatment is going to be anticoagulation like dabigatran, rivaroxaban, apixaban, etc., plus a rate control strategy. So, i.e., something that aims to control the ventricular rate, but with no commitment to restoring or maintaining sinus rhythm. So, for rate control, beta blockers are the preferred choice. In certain patients, cardioversion may also be considered, for example, in those patients with disabling symptoms or if immediate cardioversion is required, for example, those with congestive heart failure. Antiarrhythmic agents and catheter ablation may also be considered when it is appropriate to restore sinus rhythm. So, for example, if you have a young patient who is presented. Notably, if you have cardioversion, your antiarrhythmics and your catheter ablation, so your rhythm control strategies, if they fail to maintain sinus rhythm, then the rate control strategy is what should be alone pursued. Now, for patients with permanent AF in whom sinus rhythm cannot be restored, unfortunately, then you would give these people anticoagulation and a rate control strategy for management. Cool. So moving on to our next MCQ. So in a hemodynamically stable patient with either paroxysmal or persistent AF, what is typically first line treatment for these individuals? Okay, we'll wait a few more seconds. So that's almost everyone who's voted. Cool, so we'll have a look at the results. Yep, so about 70% of you got that correct. So for these sorts of patients, you would want to give them anticoagulation and a rate control strategy, so beta blockers. And depending upon the patient's individual circumstance, you can then also give any additional modalities of treatment, such as cardioversion, antiarrhythmic medication administration, and potentially catheter ablation as well. Cool. So moving on to our next section, which is going to be looking at the outlook for patients with AF, and the prognosis. So in terms of complications, AF is associated with a significantly increased risk of stroke, and it can also detrimentally precipitate acute HF or heart failure, and can also aggravate established heart failure. In terms of prognosis, this is really going to depend on a number of different factors, such as the precipitating event, the underlying cardiac status of the patient, and whether the nature of AF is paroxysmal, persistent, or permanent. Now, unfortunately, AF is associated with a reduction in life expectancy, particularly in older patients, and AF does also increase the risk of premature death in its sufferers. And about 25% of patients with paroxysmal or persistent AF unfortunately do progress to a more sustained form within about 1.5 years. Cool. And so just a couple of takeaway messages just to end the tutorial and to summarize what we've covered. So firstly, AF is one of the most common sustained supraventricular tachyarrhythmias worldwide. Patients that present with AF will frequently have other coexisting cardiac and other non-cardiac conditions like hypertension, coronary artery disease, valvular disease, heart failure, and obesity. When diagnosing AF, you really want to be looking at the ECG trace, which shows an absence of a P wave and an irregularly irregular QRS complex. The treatment strategy that's ultimately going to be employed really does depend on the severity of symptoms, the duration of AF, the type of AF, and the presence of comorbid conditions. Overall, treatment involves correction of the abnormal rate via a rate control strategy, i.e. with your beta blockers, or a rate control plus rhythm control strategy, with your rhythm control being cardioversion, antiarrhythmic drugs, and or catheter ablation, alongside anticoagulation in high-risk patients. Ultimately, the prognosis will depend on several factors, a few of which are the underlying precipitating event and the overall nature of AF itself. Cool. And so that ends my tutorial this evening. Thank you all very much for listening. I hope you've learned something useful about AF and how to manage patients that may come your way. And I'm very happy to take any questions. And also here is the feedback slide in case you'd like to leave me some feedback, which would be very helpful. So hopefully in the future, I know how best to improve my tutorials for the future. Yep, so we have a question that's come in, and that's from Andy. And he said, can you go through the use of adenosine and other drugs? So we didn't discuss the specific drugs in this tutorial, but I'm more than happy to generate some supplementary slides actually that would help go through those drugs for you guys. And then hopefully those can be distributed so that you have something that you can refer to. You're welcome. I can see some comments coming in from the chat. You're very welcome for the tutorial. Cool. And so, oh, you're very welcome, Andy. Cool. And so I think if there are no more questions, I'll give it maybe a few more minutes just in case. Cool. So if there are no more questions, then thank you all very much again for listening this evening. Please do fill out the feedback form. I'd really appreciate it. And I hope you all have a very lovely evening. Thank you.